everybody. Recording live from somewhere. This is Zach, couples with episode number 102 of the Movement Debrief. And tonight, folks, is going to be interesting. We're going to talk about deadlift stance. How do you select the best deadlift stance to maximize your gains or whatever your goals are for deadlifting? I'm going to give you the answer. We're going to talk about measuring hip rotation. What does measuring the hip rotation in various positions do? How might that change your measures? Which ones are worthwhile to utilize? Stay tuned. And last but not least, we're going to talk about hemorrhoids. Yes, we're going to talk about hemorrhoids. Why are they not the shit when you shit? These are questions that have been asked by the people. They'll be answered for the people right here by this people. Fam recognize fam. Without further ado, let's debrief, shall we? The first question comes from Ruben Rothel 3000. I hope that's totally his real name. But here's what Ruben Rothel 3000 has to ask. What about the infrasternal angle in relation to deadlift stance? Is there a stance more optimal based on your infrasternal angle? Great question, Ruben Rothel 3000. Let's dive in. What is a deadlift? A deadlift is a hinge type action where the hips or the pelvis translates posteriorly, loads typically a lot more structures on the backside of the body. If we zoom in to the hips, got my pelvis right here. If the pelvis is moving posteriorly in the deadlift, the only way that's going to happen is if the sacrum has the ability to nutate, which would cause the sacrum to tip forward. The innominates would spread apart. Changing the axis of movement in the pelvis, because I got all this space here I can move into, and it's going to shift the weight backwards. It's going to prevent shifting down due to the orientation of the sacrum. So that's a deadlift. Now we have to ask ourselves, which infrasternal angle is going to be better at deadlifting? And the answer for that would be wide. Here's why. A person who has a wide infrasternal angle exhibits an exhaled axial skeleton. What an exhaled axial skeleton involves as a level 1 compensatory activity, and I should say generally, this is not always the case, but for most people who are wide, the sacrum is going to be more nutated, the lumbar lordosis is going to be increased, the upper thorax, the thoracic spine is going to be more flattened, and head position, of course not always, this is like level 1 compensation, is going to be more that military-based posture. So they're really good at those types of strategies. So if I'm in a nutated orientation and I can't go the other way, when I go to do some type of lower body activity, that's going to result in more posterior displacement of the pelvis, aka hinging. Whereas if I'm an individual who has a narrow infrasternal angle, all those orientations are flip-flopped. So this individual, if they're a narrow infrasternal angle, exhibits a more inhaled spinal orientation, which would involve the sacrum being in more counternutation compared to the wide. There's going to be a reduction of the lumbar spine curve. It's going to be increased thoracic kyphosis, more of a forward head posture. Of course, there's compensations that can go on top of that. Some narrows can exhibit more exhalation-based strategies, but that's the general trend. These individuals are going to be better at squatting because when you squat, you need the sacrum to counternutate so you can drop the center of mass downward. That would be the difference in infrasternal angle presentation and in terms of who's going to be a better deadlifter versus squatter. There's probably a reason why most elite level power lifters are big dudes and dudettes. You know, they have that wide base of support, larger gut, many of these qualities, and it's probably because their skeleton structure supports them performing these hinge-like patterns more effectively. Now, the question is, how do we choose the best deadlift stance? And I think we have two extremes that we can look at. We either have your conventional stance, which is a narrower stance, and we have your sumo stance, which is this wide-base stance. With the conventional deadlift, the femurs are going to be in a more internally rotated orientation and position. When I'm using a sumo stance, the femurs are going to be in more external rotation. What do each of those positions do? Well, if we go back to the squat post, or the squat debrief that I talked about last time, if I have a case where I choose a wider stance, I have a reduction in available spinal range of motion. And I'll link that post in the show notes to zachcouples.com. Squat stance. So if you ER the legs, go wider stance, less spinal motion occurring. Another thing to think about is if the deadlift involves a posterior weight shift and I ER the femurs, there's going to be more bias towards concentrically orienting or shortening the gluteus maximus, since those are your big external rotator muscles. So essentially what I have with a case where I have a wider stance is I'm got more compressive strategy going on the posterior side of the pelvis, as well as I'm going into the deadlift, creating more of a compressive strategy on the anterior side. So essentially, what the sumo stance does is it restricts all of the available motion, that can occur in the pelvis. For elite level powerlifters, especially if they're wearing gear, this could be useful because now I don't have all of these increased degrees of freedom to worry about, which could potentially make me more efficient when completing the lift. However, that also could come with a cost. If I have increased compressive strategy, that could abnormally load the tissues over time, leading to restrictions in range of motion. That's going to impact how the synovial fluid is dispersed across the joint surfaces, and it could lead to potential injuries or other long-term strategies or long-term consequences. So there is a cost to having a wider base stance. Moreover, if I look at the mechanics of the pelvis as I go into nutation and shift the weight back, the nutated position of the pelvis increases femoral internal rotation. And the reason why that is because as I nutate the pelvis, the acetabulum orient more anteriorly. So there's the more that I nutate and push the hips back, the greater internal rotation demands occur. If I have a wide base stance and I'm compressed front and back, many individuals who favor a wide base stance, and maybe they have a lot of external rotation at the hips, might not have enough IR to shift the weight, their hips posteriorly. Or they might take up all the slack that they can, and maybe they don't have the ability to achieve a good depth, especially if they have anthropometrics that won't allow for that. So there could be other areas that could be negatively loaded in order to create the lift. Maybe what they have to do is they have to fold in half more at the lumbar spine in order to reach the bar and pick it up, because they can't get that movement at the pelvis because they lack the enough nutation to shoot the hips posteriorly. We see this a lot with some people where you have them hinge and they push the hips back and they can't go any further, or like on an elevated deadlift. So what they have to do is they actually have to flex the lumbar spine in order to pick the weight up. Well, that's where we have a situation where now I am, in theory, doing an activity that favors spinal exhalation-based mechanics, but then I go and flex the lumbar spine, which is more inhalation-based, and I'm also probably doing it from a disadvantaged position. That could potentially be problematic. Not always, but potentially. Whereas, if I have a narrow base stance and the femurs are in IR, I'm allowing for more spinal motion to occur. This might actually allow me to drive more nutation because I'm putting the femurs into internal rotation, giving me more degrees of freedom to shoot the hips back, especially if I have internal rotation available. And when we're talking about deciding which is better for me, a lot will depend on what range of motion you have available. If you are someone who, and of course there's also anthropometrics involved with this, and there's a good article that I'll link in the show notes that goes over some of the anthropometrics required for a deadlift. So, for example, people with long arms might do well with conventional, people with shorter arms might do better sumo. But from a range of motion perspective, someone who lacks internal rotation may find it easier to take a wide base of support or a wide stance in order to complete the deadlift. People who have lots of internal rotation, me for example, I feel much better with a conventional stance. So then do we say, well, okay, I have these range of motion restrictions, I'm just going to go do this deadlift pattern and that's just work with what I got? Well, depends on your goal. If you are an elite level power lifter or you're competing in powerlifting and your goal is to move as much weight as possible, I got no beef with that. If your goal is to improve your health, maximize movement options so you have healthy joints and healthy tissues and you're loading everything equally and evenly, that might not be the best strategy from a loading perspective. What I would prefer most people do is they try to drive the range of motion that they don't have so they have the option to do either of those extremes. I would like power lifters or people who have more of a wide stance when they lift to make sure that they are restoring enough hip internal rotation so there's better load distribution across the hips, and that might actually allow them to get more comfortable in a conventional stance. You could even argue using a conventional deadlift for those people may improve hip internal rotation, and I've had that happen with some individuals just by teaching them to deadlift effectively with a narrower stance. And potentially vice versa. If I got someone who's got no ER, maybe I want to do activities to improve hip external rotation so they can achieve that wide stance if they so desire. I would say practically from my clientele, who's general population or a lot of fitness professionals who are looking to move better and feel better, not necessarily an elite powerlifter, I would try to get most people towards a more conventional stance. And what I would suggest, like I did, and the reason why that is because it allows for that increase in hip internal rotation range of motion, which many people are missing. And I would hope to do supportive activities that allow that individual to get that internal rotation range of motion. But as I suggested for the squat, I would approach choosing the best stance for you the exact same way we did so with the squat. So as I had stated with the squat, give yourself a side view, find out how, or the best stance width that you can attain that allows for vertical displacement of the pelvis as you complete the squat. For the deadlift, you want to achieve a foot stance that allows for the most posterior displacement of the pelvis. And what I don't want is that shooting the hips back posteriorly and all of a sudden you got to bend at the lumbar spine to get to the barbell. You want to see how far you can move your hips back before you do that tilt downward. And wherever that is, if it allows you to get to the bar, that's probably your sweet spot. But make sure you're doing activities that promote improving the range of motion restrictions that you may have. So to summarize this great question by Ruben Rothel 3000, the difference between a wider stance and a narrower stance: wide stance needs less internal rotation, narrower stance needs more hip internal rotation. The deadlift as a whole ought to involve more nutation so that the hips shift posteriorly. Ideally, you want to restore range of motion in a manner that allows you to do both. If you're trying to pick the best deadlifting stance width for yourself, give yourself a side view, find out how far you can shoot your hips back before you got to flex at the lumbar spine to pick up the weight, and that's probably a good stance width for you to pull some heavy-ass weights off the ground. Ruben Rothel 3000, thank you for that awesome question. Now, if you're wondering, well, Zach, maybe I'd like to learn more about the differences between squatting and deadlifting, or you're uncertain how to maybe improve some of the range of motion restrictions that I talked about, and it's cramping your deadlift gains or your client's deadlift gains. Or maybe you hurt, and that's why you can't deadlift. Well, there's an answer to how you can make yourself move better and deadlift effectively, because we do go over this at Human Matrix. And folks, ladies and gentlemen, the 2020 schedule is up. There might be a couple more coming on the list, but I want to talk about them. Before 2020 is over with, we got November 23rd and 24th in New York City. That one is selling really well, so please come to that. First one of the new year, January 25th and 26th in Scotts Valley, California. That's outside the Bay Area. April 4th and 5th, Atlanta, Georgia. May 23rd, 24th is in Dickinson College. That's in Carlisle, Pennsylvania. June 6th and 7th, Minneapolis, Minnesota. August 1st and 2nd, we are in Boston, Massachusetts at Pure. September 12th and 13th, for you folks in Canada, we're in Montreal. It's going to be off the Heezy at my boy Jordan's spot. Holla, I see he's tuned in. And October 3rd and 4th in Ann Arbor, Michigan at my boy Mike Koval's spot. Also, if you want me to deep dive even further into the differences between squatting and deadlifting, because that is the topic that I'm going to be discussing at The Uprising. The Uprising this will be in Boston, Massachusetts. This is going on at February 8th and 9th. There's going to be myself, my boy Pat Davidson, who's going to be talking about some really cool stuff about how to improve movement qualities with minimal assessment. And we got Seth Obers, who's going to be doing his thing, talking about all types of things related to stress, self-regulation, and all that. That's going to be February 8th and 9th. The early bird is coming up, is getting there, January 3rd. So please sign up for that. It's going to be a really good experience. The first one sold out. I anticipate that this one will as well. So get your tickets sooner rather than later. Without further ado, though, the next question comes from Andy. Here's what Andy asks me. What's the difference between measuring hip rotation in sitting, prone, and supine? Awesome question. Well, there are quite a few differences in terms of the range of motion that you can see in each of these positions, and it's very different for everyone. I listed a study in the last post. I'll link that same study in the show notes, a hip IR study, where they looked at chillins and they measured who potentially had anteversion or retroversion, and they measured hip internal and external rotation in the prone and supine position, and the measures were all over the place. I just have this other study that I just came across. I'll link this one in the show notes too. Hip rotation range of motion in sitting and prone positions in healthy Japanese adults. Same deal. The measures are different in each of these positions, so you're going to get some different values. Now, classically, there's a few things to consider when we're talking about the differences between prone, supine, and sitting in terms of what's going on at the femur. So classically, they would tell you if I'm in the prone position, the hip ligaments are a bit more laxed. So generally, there's more motion available when you're measuring prone with the hip extended. When the hip is flexed, the ligaments are more taut, so that might bias your measures a bit differently. And generally, range of motion is less in that position. Not always, but less. But I'm not overall enthused by only that, because I think there's several other influences that we don't take into consideration when we're looking at measuring these hip rotation measures in various positions. One thing to consider is what is the relative orientation of the pelvis in each of those positions. For example, if I'm in the prone position, the pelvis, to a degree, is probably going to be in a bit more anterior orientation, just because of the prone position creates general extension throughout the body. And so that's going to influence the measures that you get when you are chest testing in prone. There's a reason why a lot of individuals will have a lot more IR in the prone position than they will ER. Well, if I'm anteriorly oriented, the femur is going to fall more into internal rotation. That may signify that you have more IR available there. When I go to the sitting position, if I'm sitting, there's a reason why I haven't been going to sitting as much. There's a lot of factors that could influence the orientation or the range of motion that's available. One, I have both hips flexed. So if I'm in a more flexed position, depending on what's going on at the pelvis from a sitting perspective, that could bias more ER or IR. Let me unpack that a little bit. If you got someone who's sitting up nice, tall, and proud, that might actually anteriorly orient the pelvis. So you have a situation where they're in flexion and IR. So if I anteriorly orient the pelvis, if you look at some of the research in individuals who have hip impingement, this anterior tilt has been shown to actually create a loss of internal rotation. So you may have a situation where this person does not have much IR available, based on this case right here, in this particular position with the hips flexed. What if you got someone who's slouching and chilling like Bob Dylan? Well, that might actually posteriorly orient the pelvis more. If I posteriorly orient the pelvis, that could potentially take care of or eliminate that restriction that we had with the anterior orientation of the pelvis. And they may actually have a lot more range of motion available. That's one reason why I've switched away from utilizing the sitting position, is because we have all of these other confounding variables that could potentially negatively bias our testing, even if we're consistent. The one thing that we can't really keep consistent is this person sitting in the same orientation each time. That leads me to the next point, which would be testing in supine. Now, generally, I will say the supine position is going to be the most restricted out of all three of those positions that I had mentioned. And the reason why that is because when I bring one hip in flexion, which depending on the degree of flexion may drive more counternutation at the pelvis, I have the opposite strategy occurring on the opposite side. And if that side is restricted, you may actually get limitations in rotation because of that asymmetry that's created within the pelvis. You can change this pretty quickly by tipping the bottom of the pelvis, so you change the orientation of the femur on the acetabulum, and that can influence range of motion. But just realize that that is a factor to consider when you're measuring one hip flexed versus the other hip extended. So let's go through that again. Prone position, you may be more biased to anterior orientation. Sitting position could go either way. It depends on the sitting orientation and how well your client manages gravity. Supine position, you got to deal with the opposite leg, but there are more constraints, so there's less room for error. So considering all that, what should you test? What's relevant? I think as long as you are consistent with any of those, all of them are fine to make decisions. Practically, I don't use hip external and internal rotation to make decisions early on. Usually, I've cleared up a lot of my other tests, i.e. straight leg raise, hip flexion, hip extension, those types of tests, before I even think about tackling hip IR. Because a lot of times if you clean up even there's just those three alone, you'll see most hip rotation clear up. It's only after that in which I would actually do something that might specifically drive hip internal rotation, maybe something that's more unilateral. But I typically will stick with the supine position only, and the reason why that is because I think the seated position is a little bit too messy because of some of those influences I had mentioned before. A lot of times with that, the prone position, I think because of the ligament laxity, it doesn't really give me any valuable information because generally most people are going to have large degrees of range of motion available there. So my bias is to go with the supine position, and I just use that as a marker to let me know that I'm heading in the right direction with my measures. And that's really it. So to summarize your great question, Andy, the difference between hip rotation, you will get various measures across the board, but prone position is going to lead to a little bit more anterior orientation of the pelvis. The ligaments at the femur are a bit more lax, so you generally get more motion available there. Sitting position really varies depending on what your sitting posture is, so you can have numbers that go all over the place. Makes it tough to standardize. The supine position, you have to deal with an asymmetry created in the pelvis when you measure hip ER and IR. So that's also something to be concerned about. And also with that too, depending on the degree of hip flexion that you put yourself in, that can also change your measures. So That one also too is hard to be consistent with at all times, especially because you can move the hip into more adduction or abduction. But I would choose whatever of those tests you find yourself most consistent with. And really, hip rotation is just a marker to let you know that you're heading in the right direction with a lot of your tests. I think there's a lot of other tests you could go to that you should try to clear out first before really diving into your rotational changes, because a lot of times if you clear some other tests, ER and IR clean up pretty quick. So, Andy, awesome question. Thank you for asking that. The last question comes from, this is an anonymous person, so we'll call him Andre 3000. So here's what Andre 3000 asks me. Dude, speaking of stress, any suggestions for a stressed out butthole, i.e. hemorrhoids? Have you treated any patients with this issue? Any specific things you have found to be helpful? Any common presentations in terms of infrasternal angle or infrapubic angle? Andre, this is a great question. What are hemorrhoids, first off? Hemorrhoids are bulging veins that happen in the anal region because of increased pressure in the pelvic floor. Usually, if you are straining when you're going to the bathroom, that is there's a high chance you're probably going to develop a hemorrhoid by doing that. So what we have to ask ourselves is, what are all the factors that could lead to straining when you're going to the bathroom? I'll go with my bias first. My bias is from a movement perspective. Well, when you go to the bathroom, ideally the pelvic floor should relax and the anal sphincter should relax enough to where you can defecate, i.e. it needs to eccentrically orient to allow that to drop. Well, if you can't do that and you have to increase pressure to evacuate poop, then you are putting yourself more at risk for hemorrhoids, because as the pressure increases in the pelvic floor, that increases blood flow into the veins. Might be too much to handle, just as like you would have the same issue with hypertension, right? If I have too much pressure coming out of the heart, and you could get a bulging of these veins. So that's not desirable. So the key would be to try to create that relaxation component of the pelvic floor. A simple way to do this, although it doesn't always work, but a simple way to do this would be to get something like a squatty potty. That is the thing that the squatty potty sold people on, is the position of maximal hip flexion in a deep squat allows the pelvis to tip posteriorly in the sacrum to relatively counternutate, which would make the pelvic floor more eccentric. It would reduce some of the pressure within the pelvic floor and allow you to go to the bathroom. And that is worthwhile. I've given a lot of people who've had hemorrhoids or straining when they go to the bathroom, prescribe them a squatty potty, and that fixes a lot. So you could also do supportive activities that replicate the same position as the squatty potty. So working towards getting a full deep squat, that could be a great way to influence that same orientation at the pelvic floor. And there's a gang of squat videos on my site and a lot of my contemporaries and colleagues that you could go into to make that happen. That's probably the most important thing I would argue from a movement perspective, is you have to be able to get the pelvic floor to relax and eccentrically orient so you can allow the poo to come out. But I will say this, that's an important piece, but it's only one piece that goes into the ability to defecate. The relative hardness of your stool could also, or could, but definitely will play a role in your ability to have to strain to go to the bathroom or not. If you have any gut motility issues, perhaps you have reduced gastric emptying, and there's stuff that's staying in there longer, and then the poo gets harder and more compacted, that could potentially make the poop be less effective at exiting. Same thing if you're consuming a very low fiber diet. If you don't have the fiber to build up enough bulk in the poop, that could also not make your poop silky smooth. So if you have any digestive issues or now that's funny. Now if you have any digestive issues, or you have any gut dysbiosis, or you have a crappy diet, those would also be worthwhile things to go into. It's a little bit area out of my expertise, but that was one reason why I worked with Ben, because I was having digestive issues. And I'll link Ben House, of course, who I'm talking about. I'll link into the show notes. But by working with him and doing some things to find a diet that was right for me, I was able to clear up a lot of those things. And I mean, like things such as any infections or things of those nature, that can most certainly influence your relative gut motility or lack thereof. And that might require working with a functional medicine practitioner. And that would be something I would also strongly consider if you are dealing with hemorrhoids or any type of constipation. You probably should figure out what factors could be influencing your ability to go or not. The postural component or the movement component is only one piece. We also have to ensure that the quality of your poo is on fleek, so to speak. So I would definitely look into a functional medicine practitioner if you're still dealing with this stuff. And I linked Brian Walsh's post that happened this week. While I don't offer many practical tips on what you could do, a lot of his information is gold when it comes to restoring the healthiness of your gut, and I would definitely look into that route. And it's a lot more complicated than just consuming a lot more fiber. And in fact, for some people, that's not the best course of action. Another book you might consider is Dr. Ruscio's Healthy Gut, Healthy You. I'll link that in the show notes as well. I thought that was an excellent starter for if you have a gut issue and you don't have other comorbidities and you just want to play around and see if there's some things that could improve your gut motility. That's another really good book to look into. So to summarize your question, Andre 3000, hemorrhoids, bulging of the veins within the anal region, likely due to increased pressure, either from a postural component with concentric orientation or shortening of the pelvic floor, as well as the health of your poo. If your stools are too hard to pass and they're not silky smooth, you're going to have some issues. You're going to be more predisposed to having hemorrhoids. The solution would be to make sure that you can restore the movement options in the pelvis. A simple way is to get a squatty potty, so you can get your hips into that position that allows the pelvic floor to relax, or do things that get your hips in this position, like squatting or sitting in a squat position and breathing. Things of those nature. They work great. Also, make sure your poo game is on fleek. You might want to consider adjusting your diet in a favorable manner. I think Dr. Ruscio's book is really good for that. But if you're having other gut issues along with getting hemorrhoids, like you're bloating, or there's certain foods that you can't tolerate, it might be worthwhile to work with a functional medicine practitioner. My guy's Ben House. I don't know how many people he's seen, but Brian Walsh is also very, very good. So I would strongly look into both of those components when you are talking about keeping your butthole healthy. So thank you for that question, Andre 3 Stacks. I think that's a good stopping point for us tonight. I want to thank all of you beautiful, sexy, outstanding people for tuning in. And if you want to learn more, you want to figure out, hey, where else can I learn more of this stuff, Big Z, aside from Human Matrix, here's where you can go. Go to zachcouples.com. What I'd like you to do is subscribe to the newsletter. We'll have 5 hours of talks on the newsletter. You'll have a course that goes over a lot of basic movement mechanics. You'll get a free acute to chronic workload calculator. You'll get weekend goodies every Friday. And of course, updates to any products or anything like that I will be releasing. Once you're there, I would also check out my 3 services. I offer movement consultations. Perhaps you want to know how to squat more effectively, and you're having a hard time doing that, just playing around with some of the stuff that I put on the internet or my colleagues. Well, there's a good place you can do that. It's with a movement consultation with me. What we can do is we'll assess your movement remotely. We'll figure out what areas you struggle moving in. We'll do some activities on the spot, see if we can get you moving more better, and that can do a lot of wonderful things for you from a health and performance perspective. I've also done this a lot with trainers, or I've co-treated with clinicians, so there's lots of options that we can do with this. Another option, if you want to take that to the next step, and it's like, yeah, Zach, my poo game's on fleek, but I want to squat with some heavy weight and stuff. Well, I can also take your movement consultation that we did and design a program specifically tailored to your movement needs while respecting your fitness goals. That's where online training comes in. Definitely check that out. Or if you want to learn how to do that with your people, or you want some help organizing, because as I'm sure many of you know, I'm working a full-time gig, kind of full-time-ish gig, doing this stuff online, trying to make sure my girlfriend doesn't hate me, all this kind of stuff. I've had to be very militant with scheduling things. So if you're having a struggle point with that, that's where my online mentoring program comes into play. I'd be happy to help you sort through either some of the movement side of things or how to implement this stuff that I'm talking about with your specific population. Because I speak with my population, and that's my bias. It might be different from yours, but that doesn't mean that we can't have discussions and figure out how this stuff might best fit for the people you work with. Once you've scoured ZachCouples.com, because I got a gang of posts there too, definitely sign up for me on iTunes and Stitcher at the Zach Couples Show. Because guess what, folks? There's 101 other debriefs, and it's not safe to watch YouTube while you're driving. So you might want to go ahead and check me out on iTunes or Stitcher. Please leave a review while you're there so we can help the fam grow. I'm also on social media. I'm on that Instagram, baby, at Zach, Z-A-C, Couples, C-U-P-P-L-E-S. I'm on Twitter, that's at ZCouples. Facebook is at ZCouples, and I'm also on YouTube. If you search Zach Couples, you'll find a gang of exercises, lots of videos and stuff. I would definitely check that out. I want to thank all of you wonderful, beautiful, sexy, outstanding people for tuning in. I'll see you next week, but keep it real, but not to the extent where things go wrong. Stay hungry, stay learning, stay moving, and I'll see you next time. Deuces.